My name is Dr. Robert Bourge. I'm at the University of Alabama at Birmingham. I am professor of medicine, radiology, and surgery. I just presented at the International Academy of Cardiology annual scientific session held today, 2018, in Boston, Massachusetts. My lecture was, open quotes, pulmonary arterial hypertension. Have we made it an almost forgettable disease over the last 25 to 30 years? Pulmonary arterial hypertension has been my passion for many years. I started the first pulmonary vascular disease program in the Southeast United States back in 1986, because at that time we opened our heart-lung transplant program and suddenly had scores of patients being referred for heart-lung transplantation, the typical therapy for the disease at that time for very ill patients. Unfortunately, most patients died before we could find a heart-lung block for them. Because of that, I became interested in medical therapies and other therapies for the disease, and since then I've been involved in just about every clinical study that has been in this population. One of the reasons for that is because I have so many patients and have treated so many patients. At first I was by myself, but now fortunately I have 6 colleagues who see a large number of patients with pulmonary vascular disease. Today I concentrated my talk on WHO type or class 1 pulmonary arterial hypertension, typically referred to as idiopathic pulmonary hypertension and including heritable pulmonary arterial hypertension. Early on in the first medical therapy study, the first randomized study of epoprostenol or Flolan, we showed in 91 patients that we actually improved survival, and that led to the approval of epoprostenol, trade name Flolan, for the use in these patients, and we finally had something to treat them with. Unfortunately, it has a very short half-life and has to be given intravenously, continuously. Interruption of the drug often resulted in death of the patient because of its very short half-life. Fortunately, through a lot of clinical studies and investments by a lot of companies, a lot of individuals, we now have a huge number, relatively, of therapies for our patients, which we believe improve survival, although the only study to definitely prove improvement in survival was that original Flolan study. Part of the reason for that is that we think it's not ethical to randomize patients to nothing anymore, because they will die almost certainly. So patients are already on drugs usually when we try other drugs. Over the last few years, actually 14 or 15 years, I've concentrated in making the administration of prostanoids like epoprostenol much better for our patients. Unfortunately, prostanoids, the newest one being treprostinil, needs to be given intravenously, which gives the patient the risk of infection through a tunnel catheter and an external pump, or subcutaneously, and unfortunately that leads to site pain where the needle goes under the skin. I had the idea quite a few years ago of using an implanted pump, the Synchromed pump from Medtronic, along with the new catheter developed by Medtronic, which was designed specifically so it could not kink and could not clot, because it has a valve on the end of it. Fortunately, I was able to, with a lot of cajoling and a lot of pushing, to get Medtronic and also United Therapeutics to invest in this study. It took us 5 years to get it started. We completed the study a year and a half to 2 years ago. It's been published, and we saw a drop in the episodes, the possibility of a catheter-related infection or other complication from an average of 1.5% to 2% per 1,000 patient years down to 0.28. Huge decrease. We now have over 100,000 patient days of therapy with this catheter and this pump, and we've not seen any catheter-related complications. We're about to start, hopefully, another study using a slightly higher concentration, so patients will go up to 3 to 4 or even more months between injections. The pump is put under the skin in the abdomen, and patients come into clinic and we fill it externally. huge improvement in quality of life, as you can imagine. So the combination of that therapy with prostanoids, which we give to sicker patients in general, and oral medications, primarily the use of a PDE5 inhibitor and an endothelin receptor antagonist, were able to keep most patients alive and doing well for many years. Some patients need transplantation, but compared to the past, very few. When we started, 9 out of 10 patients we treated required transplantation. Now, only 1 out of 10. And we're able to keep patients, for the most part, stable. Not all, but most stable, until we're able to find a heart-lung block or a double lung block, depending on the situation. So my patients would all tell you things have markedly improved. In fact, I still care for one of the patients who was in the original ipraprostenol study in 1990. She was randomized to placebo. It was a single blind arm. I knew, but she didn't know what she was on. And she survived through the randomized trial. After 12 weeks, she got on open label drug, and within 6 months, she went from class 4 on 100% oxygen, unable to walk or get out of bed without syncope in the hospital, to playing tennis doubles with her husband. And over the years, she's been in virtually every study that I've tested a drug in, and now is doing well with the implanted pump. And now she's had it in for over 5 years without any complications.